Hi everyone, my name is Elizabeth Brooks. I'm a second-year pharmacy student at UNC, currently on rotation at the Cone Health Family Medicine Center. Today we'll be going over the latest pharmacy news for the month of April. For this month's news, we will discuss the recent FDA updates to opioid labeling, the Medicare expansion of continuous glucose monitor coverage, and the COVID-19 vaccination updates specific to the Cone Health system. The first update that we will discuss is the FDA update to opioid labeling. The update pertains to both immediate release and extended release opioid pain medications, providing additional guidance on how to safely prescribe them. The updates include a new warning about opioid-induced hyperalgesia, a statement on the risk of overdose increasing with a dose increase, and a newly reordered boxed warning to elevate the importance of certain adverse effects. The mechanism of opioid-induced hyperalgesia, or OIH, is not fully understood, but is becoming more prevalent with the number of people on opioids for chronic pain increasing. Cases have been reported with both short and long-term use of opioids. It is thought to be a neuroplastic change in pain perception that augments pain sensitivity. It occurs when an opioid analgesic causes an increase in pain or an increase in sensitivity to pain, and it appears to be a distinct, definable, and characteristic phenomenon that could explain loss of opioid efficacy in some patients. Symptoms include increased pain with a dosage increase, decreased pain with dosage decreases, and allodynia, which is pain due to a stimulus that would not normally cause pain, like a feather landing on the skin. Symptoms may suggest OIH only if there is no evidence of underlying disease progression, opioid tolerance, opioid withdrawal, or addictive behavior. The type of pain experienced might be the same as the underlying pain, or it might be different from the original underlying pain. A new warning for this phenomenon has now been added to opioid labels. For patients experiencing OIH, you want to consider decreasing the dosage or switching to a different opioid moiety. Probably the biggest challenge to recognize as a clinician with OIH is being able to differentiate between tolerance. Clinicians also have to factor in progression of the disease process, interval injury, and clinical exacerbation of pre-existing pain. Tolerance is a pharmacologic concept characterized by decreasing efficacy of drug. With tolerance, the progressive lack of response to drug requires increased dosages and can be overcome this way. Alternatively, OIH is a form of pain sensitization induced by the drug, so you cannot increase the dosage to overcome the increased pain, as this would worsen it. This type of pain produced by OIH is typically diffuse, less defined in quality, and it extends to other areas outside of pre-existing pain. Thus, reducing or eliminating the opioid is the best option. The FDA has added a statement on overdose risk in the dosage and administration section. On the left is the former label and the right shows the new one. You can see that it now has been updated to say that because the risk of overdose increases as opioid doses increase, reserve titration to higher doses for patients in whom lower doses are insufficiently effective and in whom the expected benefits of using a higher dose clearly outweigh the risks. The statement is also added to the important dosage and administration instructions for extended release analgesics. The FDA has also reordered the boxed warning for opioids. On the left is the former and the right shows the new order for the boxed warning. As you can see, life-threatening respiratory depression has moved to be the second warning, and risks from concomitant use with benzodiazepines or other CNS suppressants has moved up on the warnings as well to elevate the importance of these adverse effects. OIH is a less recognized effect of opioid therapy, and with the new statement being added to the opioid label, it is something to consider with suboptimal opioid response in patients. It is also important to be aware of black box warnings and the overdose risk statement added to the label. These updates serve as a reminder to provide detailed counseling and documentation for patients prior to starting opioid therapy or dosage increases as part of a comprehensive informed consent or agreement. The next update we will discuss pertains to the Medicare coverage update regarding continuous glucose monitors. Continuous glucose monitors allow diabetic patients to have continuous blood sugar readings for 24 hours. These are the most common CGMs that we see. Dexcom sensors last for 10 days and Freestyle Libre sensors last 14 days. Prior to April 16th, Medicare had key restrictions for CGM coverage as it was limited to patients who met the criteria of insulin administration 3 times daily. As of April 16th, Medicare has removed the key restrictions for CGM coverage. Patients now must meet the initial coverage criteria of having a diagnosis of diabetes, the practitioner has determined the beneficiary has sufficient training using the CGM, and the CGM is being used in accordance with FDA indications. The following slides will continue to explain the initial coverage criteria. The initial coverage criteria now states that the beneficiary for whom the CGM is prescribed must meet at least one of the following requirements. They must be insulin treated with at least once daily administration, or have a history of problematic hypoglycemia with documentation of at least one situation of a recurrent level 2 hypoglycemic events or one singular level 3 event. This now opens CGM coverage to both insulin-treated and non-insulin-treated diabetic patients. Recurrent level 2 events for problematic hypoglycemia is defined as a blood glucose less than 54 that persists despite multiple attempts to adjust medications and/or modify the treatment plan. One level 3 event for problematic hypoglycemia is defined as a blood glucose less than 54 characterized by an altered mental and/or physical state requiring third-party assistance for treatment of hypoglycemia. The final criteria to meet for CGM coverage states that within 6 months prior to ordering the CGM, the treating practitioner must have an in-person or telehealth visit with the patient to evaluate the patient's diabetes control and determine if criteria 1 through 4 are met. For continued coverage of the CGM, the practitioner must have another in-person or telehealth visit every 6 months following the initial prescription to document the patient's adherence to the CGM regimen and diabetes treatment plan. As of April 16th, CGMs are now available for a much broader group of Medicare patients. Medicaid and private insurers tend to follow Medicare, so we could see even more changes in the future. This is a win for diabetic patients as CGMs improve control and quality of life while reducing hypoglycemic events. We will now discuss the Cone Health COVID-19 vaccination updates based off of the recent FDA press release. The FDA has recently authorized changes to simplify the use of bivalent mRNA COVID-19 vaccines. If individuals were previously vaccinated with a monovalent vaccine but have not yet received a bivalent dose, they may receive a single dose of the bivalent. If individuals less than 65 years old have already received a single dose of the bivalent vaccine, they are not eligible for another dose. Individuals 65 years and older who have received a single dose of the bivalent may receive one additional dose at least 4 months following their initial bivalent dose. Most unvaccinated individuals can receive a single dose of a bivalent vaccine rather than multiple doses of the original monovalent mRNA vaccines. Specific to Cone Health, leaders have stated to not administer bivalent vaccines to unvaccinated patients as of now, and they will decide at a later time when this can begin. Monovalent vaccines are no longer authorized, and thus you should not administer them to patients of any age. As of now, the Novavax vaccine is still available for unvaccinated patients 18 years or older who need to be vaccinated by a certain date. This fall, you can expect updated formulations of Moderna and Pfizer bivalent vaccines. This is an overview of everything that we discussed for the April updates. Special thanks to Dr. Koval and Madison Yates for contributions to this month's updates.